Hello, my name is Chris Galton. I'm an anesthesiologist and critical care physician at the University of Rochester Medical Center, as well as a faculty member within the Division of Pre-Hospital Medicine. And I'd like to welcome you to my presentation of how ketamine can help to manage agitated patients. Our objectives today are going to be to introduce you to ketamine. Now, ketamine is a drug that's been around since 1962, but hasn't really gained a lot of traction for use in pre-hospital medicine until recently. It has been used by aeromedical services for a little bit longer, but it's really being pushed and introduced into the ground EMS services within the last decade or so. And as you'll see based on our presentation today, ketamine has quite a variety of uses that can be applicable in the pre-hospital environment. We'll also review how to manage the agitated patient, as well as how to differentiate the agitated patient from the patient with excited delirium. And we'll highlight where there are some differences in the protocols on how to treat each one of these situations. And then finally, we're really going to discuss how ketamine fits into the management of agitation and excited delirium within our new collaborative protocols. Ketamine is a non-competitive NMDA receptor antagonist, but it also acts on opioid receptors, specifically and primarily the mu and kappa receptors, although those are weak bonds. And then there also has some very weak crossover into the sigma opioid receptor. Although I don't want to spend too much time speaking of the pharmacokinetics, I think it's important to also know that ketamine is active on the monoamine receptors. It inhibits nitric oxide synthetase, which explains some of the hemodynamic properties. And then it also is a modulator of the nicotinic and weak modulator of the muscarinic acetylcholine receptors. And then finally it has some properties of dopamine 2 agonism. And these all lead to ketamine being able to inhibit serotonin, dopamine, and norepinephrine reuptake, which probably as we move on today will explain why it has some of the effects that it does. Now, the main benefit that ketamine offers us with regard to managing agitated patients is that it provides a dissociative state when administered. And it's really known as a dissociative anesthetic agent. Now, conveniently, it also provides very potent analgesia to our patients. It's a very good sedating agent and is used very frequently in hospitals and the emergency medicine setting to provide a nice, calm patient to get through some noxious procedures. Now, ketamine also is a fairly good amnestic agent, and one of the really nice side effects that it offers is that it's a very good bronchodilator, so it can be very effective in treating some of the obstructive disease pathologies that we see in the acutely ill respiratory patients. For the older members of the crowd, you may remember in the 1970s that ketamine had a strong recreational history. It's been known for many years as Special K, but also goes by K and Jet. Some people call it green, which I never quite understood. But my personal favorite street name for ketamine is Cat Valium. In emergency services and pre-hospital medicine, one of the fundamental needs that we have for the tools that we use is rapid onset, given the acute nature of the patients that we see. Now, with regard to ketamine, it has some pretty impressive data to support its use pre-hospitally. Pre-hospitally, we use ketamine in both intravenous and intermuscular forms. The onset time of intravenous use is about 30 seconds, and intermuscular use is generally between 3 to 4 minutes. Now, it can also be used intranasally as well as orally, but the onset time generally is too long to have any value in the pre-hospital environment. Now, understanding ketamine and the pharmacodynamics and kinetics of it, really you have to understand that it has different layers to it and how it works. Now, when given in an intravenous form, the anesthetic properties usually last anywhere between 5 to 10 minutes. But what's nice is that you get a nice tail to it with regard to the analgesia, which can last all the way up to 2 hours in some circumstances. When you use it intramuscularly, those times are roughly doubled. So the analgesic effects can last almost 3 to 4 hours, but really your anesthetic value is maybe on the high side. You get 20 minutes out of it. Now, we know that as ketamine is metabolized, it's metabolized into norketamine, which is a relatively insignificant metabolite. So you don't have to be terribly concerned about any kind of active metabolism of ketamine after you administer it. So ketamine is a Schedule III controlled substance according to the Drug Enforcement Agency. So we obviously have to think about it a little bit different than we do about a lot of the other medications that we use. And the fact that it is a controlled substance does, to a certain extent, limit our ability to have it available, or as available as we would like it. Now, having said that, ketamine is a pretty darn safe drug, honestly. You really don't have to adjust it for patients that have renal failure, or for that matter, patients that have significant liver failure. It's stored at room temperature, which makes it a nice shelf life, and it's fairly cheap because it's been around for so long. There really aren't any terrible incompatibilities, so all the drugs that we use can be run in the same line as ketamine administration. It is a drug that we use in the anesthesia world for pregnant patients if they need sedation, because it is known to be relatively safe in pregnancy, as well as in the immediate postpartum period for women who are breastfeeding. One of the best features of ketamine that I love to talk about is the fact that it maintains the basic airway reflexes. So all the reflexes of your larynx that you would want to remain intact even when you're in a sedated state do so when you're utilizing ketamine, which is not the case with most sedating agents. And so you can imagine how ketamine now becomes much more desirable in a situation where you have a patient who you need to sedate to get through either a noxious procedure or something of that nature, but you don't want to have to instrument their airway to safely do so. Now, ketamine also is able to counteract specifically spinal sensitization, which can reduce the risk of the wind-up phenomenon. Now, I know not too many of you know or spend a lot of time understanding the wind-up phenomenon, but that's basically a situation that you can have hyperalgesia or long-term chronic pain if you experience sharp spikes in pain related to acute stimuli. So although we usually can't stop the first stimuli from occurring, we can limit the repeated stimulus that patients may experience, and then as a result reduce the long-term and chronic effects. So I think that's pretty awesome to think about, that we as pre-hospital providers can really reduce patients' chronic pain in the actions that we take dealing with them acutely. Ketamine is honestly a really safe medication to be used in the pre-hospital environment. As it is the case with all medications that we use, one of the contraindications is a hypersensitivity to ketamine. But I would tell you, in the thousands and tens of thousands of patients that I've ever run into, I don't recall over the course of my career ever meeting someone who's had a hypersensitivity to ketamine. Now, the only other time where I really think about ketamine and whether or not it would be appropriately utilized is when you have patients who are hypertensive to start with. And the concern is that, as we'll talk about, ketamine is known to increase heart rate, increase blood pressure because of the sympathomimetic effects that it has. So anytime hypertension would be hazardous to your patients, you may want to consider whether or not ketamine would be the right choice of medications to use for that scenario. Now, just some examples of scenarios where I would be a little bit concerned about whether or not ketamine would be appropriate include patients who have symptomatic aortic aneurysms, patients with fragile cerebral vasculature where hypertension might cause a cerebral vascular injury, and then also anyone who has active intracranial hemorrhage. I think we have to be careful with, because knowing that we're going to increase the blood pressure or increase the MAP will as a result also increase the cerebral perfusion pressure, but not necessarily the intracerebral pressure. And we'll discuss that a little bit later as well. So ketamine has a lot of interesting effects. I don't know if it's really appropriate to call some of them side effects, some of them or some of them desirable effects. So we're just going to go through kind of how, or some of the things that ketamine can do. Obviously, the first desirable effect is that it's going to cause this dissociative state. Usually when I talk to resident physicians or my EMS colleagues, I refer to ketamine as causing you to think that the sky is purple and that you don't really care what's going on. So it's not as if the brain, if you would consider the brain a light bulb, whereas some of our medications turn that light bulb off, ketamine actually leaves the light bulb on, but just takes you to a place where whatever's going around you is not really relevant. It dissociates you. Now, as a result of that dissociation, some patients can have emergence reactions, which is a big concern for a lot of people. And that can lead to some agitation and confusion as the medication wears off. Now, these emergence reactions occur somewhere around 10% of the patients, and usually it's nothing that's terrible to deal with. It's just a little bit of mild agitation, and those patients can typically be redirected. I found in the past, my practice is to use a very small dose of an antipsychotic, and I find that to be very effective. But things like a small dose of benzodiazepines or a small barbiturate dose can also be very effective in treating those emergence reactions. But the other thing that we need to consider, given what we're talking about today, is that these emergence reactions may also be just unmitigated excited delirium that's also breaking through after an initial dose of ketamine. Now, ketamine also has been known to cause some increased secretions, and I usually only find that with doses that exceed 4 to 5 milligrams per kilo, which for patients who are treating for excited delirium, and in certain cases agitation, those doses are going to push up into that range. There's been some pretty good data that's come out over the last 10 years to kind of squash this idea that ketamine increases the intracranial pressure. Now, I'm going to take us back to our fundamental physiologic equations, and I don't want to spend too much time talking about it, but I think it's important with regard to this question. Now, when we think about the brain and the pressures in the brain, really the biggest thing we want to think about is what is the cerebral perfusion pressure. And that's the pressure that's required to push blood up into the brain and to properly perfuse the brain parenchyma. Now, that equation is CPP, cerebral perfusion pressure, is equal to the mean arterial pressure, or MAP, minus the intracranial pressure, or ICP. Now, we used to think that ketamine actually increased ICP, which can, as a result, reduce the cerebral perfusion pressure, or CPP. And as that's been studied over time, we've realized that ketamine does not actually increase intracranial pressure, but it does, however, increase the MAP, or the mean arterial pressure. Now, that, as a result, can increase the cerebral perfusion pressure, but the brain parenchyma is still adequately perfused when we give appropriate doses of ketamine. Now, one of the other side effects that's been spoken about, which I think has a little bit more validity to it, is that ketamine is known to increase the interocular pressure. So I generally try to stay away from ketamine on patients where increased interocular pressure would have some pretty significant negative effects. Along the lines with vision, ketamine is known to cause some double vision. And one of the more interesting features is that ketamine can cause nystagmus in some patients, usually within 2 to 3 minutes of when it's first been dosed. Ketamine also is known to cause tonic-clonic movements when you get to higher, more anesthetic-style doses. And that's once again in that 4 milligrams to 5 milligrams per kilo dose. One of the nicer things about ketamine as a sedating agent is that it's known to have positive sympathomimetic effects. So it's very typical to see increases in heart rate and increases in the MAP, or the mean arterial pressure, after given an appropriate dose of ketamine. Now, one of the drawbacks of ketamine, though, is that it's known to be a direct myocardial depressant. Now, most of us that use ketamine frequently feel that the improvements or the sympathomimetic effects of ketamine more than adequately cover the myocardial depression associated with its administration. Now, having said that, in patients with known severe cardiac disease, it's worth thinking twice about whether or not ketamine is the most appropriate agent to be utilized for your patient at that time. Ketamine can also cause some nausea and vomiting in higher doses. It's been known to lower the seizure threshold as well. Not always ideal for patients with epilepsy or a long history of seizure disorders. Ketamine is also a very potent bronchodilator. Finally, one of the concerns that we have with regard to ketamine is that it increases cerebral metabolism as well as the cerebral blood flow. And in the setting of an acute head injury, that may or may not, or that might not be the best situation. So I would encourage you to think about whether or not ketamine is the right use, or ketamine is the right medication for your needs if you have a strong concern of cerebral injury. But having said that, I typically find that the benefits far outweigh the drawbacks for most patients. Outside of the pre-hospital environment, ketamine has multiple routes that are available. But given the acute nature of what we do in EMS, really the only two routes that are viable for us are the intramuscular route and the intravenous route. Now, there may be in some circumstances uses that I could imagine for the intranasal route down the road, but at this time we're only utilizing the intramuscular and intravenous routes. Ketamine has three primary uses in the pre-hospital environment, although at this point we're only going to be using one of those. But just as a background, ketamine can be in use to induce anesthesia, which is typically what we use it for when we're performing a rapid sequence induction. And those doses vary a little bit, but generally speaking, anywhere between 2 and 4 milligrams IV, 2 and 4 milligrams per kilo IV, and 4 to 10 milligrams per kilo IM is our induction dose when used for RSI. Now, more to the point here today, we're going to be talking about inducing a dissociative state, and that can be accomplished with usually 1 to 2 milligrams per kilo IV or 2 to 4 milligrams per kilo IM of ketamine. And hopefully in the future, one use that I see ketamine really taking hold in is as part of a multimodal approach to managing pain, especially given the recent pandemic we're seeing with regard to opioid abuse in the country. The dose of ketamine for pain is very small. The side effects are very, very limited, and I see a lot of future for it. But those doses are about 0.1 to 0.2 milligrams per kilo IV. And then generally when we think about ketamine for pain, we think about its intranasal use, and that dose is 0.5 to 1 milligrams per kilo. So the agitated patient is defined as someone who demonstrates violent or potentially violent behavior. And I think it's really important to differentiate between an agitated patient and a patient who is experiencing excited delirium. Now, with regard to managing agitated patients, I think rule number one, which hopefully is the first thing we always think about no matter what we're doing, is our own personal safety. And the first thing we should be doing with any of these patients is to contacting our colleagues in law enforcement to help us manage them and to help ensure both our safety and the patient's safety and well-being. Now, the other first step we take in managing all of our patients is obviously to address their ABCs, because although they may be agitated, one concern that I always have when I think about agitated patients is that hypoxia causes agitation in quite a few patients, and it's not necessarily easy to determine the etiology of patients' agitation and violence. So before we think of agitation as being related to poisoning and overdose and some of the more standard etiologies, please have hypoxia in the back of your mind. When we think about managing a patient who's agitated, we need to think about obtaining the best physical exam that we can while maintaining our own personal safety, and that would include vital signs as well. Just like any other altered mentation patient, we want to think about, is it related to a hypoglycemic event, and if so, can we gain some objective data and check their blood sugar? And then we're going to continue on as we figure out how to manage these agitated patients, and going through a relatively simple algorithm. And the first step of that includes assessing whether or not soft restraints can be applied and whether or not that would be feasible given the patient's level of agitation. Now, another thing to consider would be when we interact with patients whose initial presentation was not to EMS but was to the police officers that we're working with. And if we have a patient that's in police custody, they may or may not be in handcuffs. But one thing that I'm a firm believer in is that any patient in handcuffs needs to have a police officer with them, and I would encourage you to do the same. Now, soft restraints and verbal redirection are not successful in ensuring the patient's safety and or your safety, then one of the things that we're going to consider are chemical restraints, and that's the focus of the discussion today. Now, generally speaking, I reserve chemical restraints for patients where all of these environmental modifications, your verbal de-escalation tactics have been unsuccessful, and soft restraints cannot be applied without causing undue duress and or harm to either the patient, bystanders, or the emergency services crew. And this is really the time when we think about utilizing the chemical restraints to provide a safer both transport and safer patient care experience for the agitated patient, as well as, and most importantly, the EMS providers. So when we reach the point where chemical restraint is the most appropriate course of action, we have to think about what agent is the most appropriate to choose to manage these individual patients. Now, one of the things that we've used in the past is the benzodiazepine midazolam, which is a nice medication. It has a very rapid onset, typically does not last too long, doesn't have a ton of respiratory depression or a lot of hemodynamic side effects, although as the doses increase, those side effects do become significantly more evident. Now, if you deem midazolam to be the most appropriate choice for your agitated patient, I would recommend doses of 2.5 milligrams if you have an IV available, or 5 milligrams if you're going to be using the intramuscular route. Now, if you've tried the midazolam and you still have an agitated patient and you need to continue to treat with more chemical restraint doses, I would encourage you to contact your medical control provider. Within that discussion with your command physician, we're probably going to be discussing whether or not we feel like another dose of midazolam would be appropriate, or whether it's appropriate to switch to something like ketamine. Now, ketamine to treat the agitated patient is a little bit lower dose than to treat the patient with excited delirium. Now, as you discuss it with your medical control physician, the dose that we would likely recommend is somewhere between 0.5 milligram all the way up to 2 milligrams per kilo IV or IM. And really the main goal that we're looking for with treating these agitated patients is not to make them comatose, but to sedate them enough to promote a safe transport to the hospital and to get them in safely into definitive care. So when we think about whether or not we have to redose some of these medications, I think that the line that I draw is that I would redose, and I will continue to redose as a physical threat continues to exist. But now once that physical threat is no longer an issue and the patient can be safely transported, there's no need to continue to dose the chemical restraints. Once the patient is deemed to be safe and can appropriately be transported to definitive care, I would once again move the patient onto the scoop stretcher or another device that's going to help you move the patient safely and keep the patient restrained and in a position that they can be treated on the en route to the hospital. Apply oxygen as needed to treat hypoxia. Apply the appropriate monitors that may include the EKG, pulse oximetry, and tidal CO2, and certainly obtaining a set of baseline vitals is appropriate. And then finally, if you haven't already, obtain an IV and check serum blood glucose. Now, for those of us that have been both fortunate and unfortunate to have seen a patient with excited delirium, it's not something that you'll easily forget. We know these patients are extremely combative. Clearly, they're not in an appropriate state of cognition. And as a result of this extremely combative state, they are highly likely to cause themselves physical harm. They're likely to put the emergency services personnel at risk. And that's not even to consider all the bystanders that may include family members or patients at parties or gatherings where this patient is experiencing this excited delirium state. Now, there's 3 hallmark features that we think about when specifically we want to utilize the phrase excited delirium on a patient presentation. And those 3 features include psychomotor agitation, that really big physical outbursts that they're having. The second feature is physiologic excitation, and the third feature is delirium. And you really need to have all 3 of these features if you want to diagnose excited delirium. Now, patients with excited delirium have some pretty standard features. They have some pretty amazing strength. These patients have been known to lift up cars, to throw people twice their weight around, which makes them very, very dangerous, obviously. They don't seem to fatigue very well, and they have an unnatural tolerance to painful stimuli, which is also makes them very difficult to control. Physiologically, they demonstrated increased heart rate. They're diaphoretic. They're very, very warm to the touch, and obviously they have this altered state of mentation, which all these things in combination make these patients very, very difficult to manage. So now what are you going to do? You got this patient that is ridiculously strong, and they're sweating, and they're uncontrollable, and noxious stimuli doesn't slow them down. What are we going to do to manage them? And as I said earlier when we were talking about dealing with an agitated patient, Rule number 1 is always, always, always your personal safety, followed by the safety of your colleagues. So the first thing you have to do is to call law enforcement, and they need to be part of your managing this patient. Similar to our agitated patient, once law enforcement's involved, we're going to check out their ABCs. We're going to make sure their airway's open because, again, we know that hypoxia can cause agitation. We're going to do the best physical exam that we can get and check out their vital signs if we're able to. Again, we're going to, if you have an IV or you can get a finger stick or you have a high suspicion of diabetes, we're going to get that objective data and catch a serum blood glucose to determine if hypoglycemia could be potentiating this situation. And then finally, again, we're going to determine whether or not soft restraints could be applied to help us provide a safe transport to the hospital. Now, once again, if a patient's in police custody and the handcuffs are already on, I think that having an officer with you is paramount, because if the officers feel that a patient needs to remain in handcuffs, that clearly they feel that your life is threatened. And if that's the case, then I would prefer the men and women in law enforcement to be riding with me. Now, certainly if we've tried all these tactics and we're not able to control the patient, we have to move on to chemical restraints. And the way that we're going to chemically restrain a patient with excited delirium is certainly a little bit different than the approach that we take to manage patients with agitation who may be a little bit more redirectable, who may not be quite as violent, and certainly and most likely are not delirious. Now, if we get to the point where we feel that chemical restraints need to be deployed to help manage our patients with excited delirium, we have two primary choices. The first of which is midazolam, and the second of which is ketamine. Now, I'll tell you about midazolam, but I really have to tell you that I think the most appropriate choice in almost every situation with regard to excited delirium is to utilize ketamine. If midazolam is the choice that you make for whatever reason, I would encourage you to use a dose of 10 milligrams IM. Now, if ketamine is determined to be the most appropriate choice, the dose for excited delirium is 250 milligrams IM. Now, if you feel that a weight-based dosing for the intramuscular ketamine would be more appropriate, I would recommend you contact the online command physician to discuss the dose that you think would be the best to utilize. Now, if you give this dose of either the midazolam or the ketamine, I would encourage you to wait approximately 5 to 6 minutes. So after you've waited the 5 or 6 minutes, if you notice that the patient continues to be a physical threat and cannot be safely transported to the hospital, I would encourage you to either switch from the midazolam to ketamine or to redose the ketamine again at 250 milligrams intramuscularly. If you have redosed ketamine twice or have given a full dose of midazolam followed by a full dose of ketamine, and the patient continues to be violent and is not able to safely be transported to the hospital, I would encourage you to immediately contact the online medical command physician and discuss the most appropriate course of action to safely get that patient transported to a site of definitive care. Once you've obtained control and the patient is no longer a physical threat to you, it's appropriate to remember that this patient is still a human being. This patient may or may not understand what's going on. They may or may not have an appreciation as to why they were agitated to begin with. So we have to go back to all of our fundamental treatment. Let's place the patient in a proper position where you can safely transport them and still provide care to them. In a lot of cases, I find that using the scoop stretcher is a nice way to comfortably move patients while still being able to restrain them as necessary, and then also makes for an easier transition once you've reached the emergency room. Oxygen can be applied as necessary if hypoxia is a concern. And I certainly think that once you have utilized sedating medications like midazolam or ketamine, we need to consider that the patient needs to be safely monitored. An appropriate set of vital signs should be obtained, EKG if appropriate. Certainly I think pulse oximetry and end-tidal CO2 as necessary would be reasonable to consider as well. And I think finally, if you have not already obtained an IV, then obtaining an IV after giving these sedating medications is very appropriate, as well as completing your assessment by checking a serum blood glucose level on patients with altermentation is the right course of action. All doses of ketamine will be tracked through the University of Rochester website, as you see below. And the reason that we're going to be doing that is because we know that ketamine is, and its use for ground pre-hospital services is new. We think it has a lot of great utility and a lot of applications to pre-hospital use that can make our job both safer and our patient care dramatically more effective. And for that reason, we need your help. So we're going to be tracking the data. We're going to be tracking the dosages that we're using, as well as why we chose to use ketamine. And we hope to use that data to inform ourselves as well as our colleagues at a state level, so that we can not only justify the reasons for our ketamine usage as we move forward, but also allow us to consider broadening the ways that we utilize ketamine as we move forward. So to go back and review our objectives, tonight we talked about ketamine, why it's going to be rolled out in the pre-hospital environment, and some of the features that make it both a desirable medication, and we also reviewed some of the other ways that we can use ketamine as we move into the future. Now we reviewed agitated patient management, as well as kind of reviewed excited delirium, and specifically I just wanted to remind everybody that the three features that differentiate excited delirium from agitation are: excited delirium patients have psychomotor agitation, physiologic excitation, and delirium, which is not the case for an agitated patient. And then finally, we talked about how ketamine is going to be fitting into the protocols as we roll out these new collaborative protocols that we're all very excited about, and how ketamine can be utilized to help you manage agitated patients and patients with excited delirium. And hopefully in the long run, we believe that this is going to improve both patient safety and most importantly, improve the safety of the EMS providers that will be taking care of these very volatile patients. Well, that about wraps up our discussion for ketamine today. I want to thank you for listening in. We're very excited to be utilizing this at the pre-hospital level. I know certainly at the Division of Pre-Hospital Medicine at the University of Rochester, we've been waiting for years to actually roll this medication out, and we really think it's going to dramatically impact both the safety of our emergency services providers as well as the experience that our patients are having when they're dealing with these terrible, terrible illnesses. If you have any questions about this presentation or any other pre-hospital information, I'd be happy to try and answer them. My email address is Christopher_Galton, Galton, at urmc.rochester.edu. Thanks again.